You and I use ketamine all the time, and the ER put people's shoulders back in to do this stuff. And there were these case reports of people who'd given ketamine for a procedure that also had depression. And then they're like, oh my God, I feel so much better that you've put my arm back and I don't feel depressed. We realized that one dose wasn't enough. And right now, I mean, you can speak to this much more than me, but I had 6 doses over 6 weeks, pretty standard regimen right now, which again was, I consider, life-saving. And then a few months later, I did 2 more sort of booster sessions. And that was about 6 months ago. And I still continue to feel fantastic. Still in therapy for lots of, childhood issues that are going to take a long time to work out. But I'm no longer where I was. That PTSD has been treated, the depression is gone, and I am a new man.
3, 2, 1. Lift off.
Welcome to the Ketamine Startup Podcast. I'm Kimberly Chan Ko, and along with my partner Sam Ko, we've had the privilege of helping doctors and licensed medical professionals across the United States open their own ketamine therapy clinics. On this podcast, we share the realities of starting and running a ketamine clinic, marketing it, and more. In this episode, Sam interviews Dr. Mel Herbert, an acclaimed emergency medicine physician known for his entrepreneurial spirit, philanthropic efforts, and educational innovations. As the founder of MRAP and the nonprofit MRAP Go, Dr. Herbert has revolutionized medical education, impacting over 160 countries worldwide. He is also the author of The Extraordinary Power of Being Average, where he challenges the notion that only the exceptional can achieve greatness, drawing upon his own journey from a difficult childhood to becoming an award-winning doctor and educator. Sam and Mel go deep into the mental health challenges faced by those in healthcare, Mel's personal experience with ketamine therapy, forgiveness, and so much more. As a side note, we get very personal and discuss suicide, trauma, and PTSD in this episode. So please be advised that this content may not be suitable for all listeners. Now let's get started with the interview.
Mel, you've been incredibly vocal about the importance of mental health, and especially in the field of emergency medicine. But I want to rewind a little bit and let's go back. You graduated med school from Australia, and then you made a decision to go into emergency medicine. How did you choose EM as a field?
I think like every ER doc in the history of the world, I did my PEDS rotations, I did my OB rotation, I did surgery, I did medicine, I did ER, and I'm like, wait a second, this is different than all those other ones. And what I really liked about it, I liked the fact that it was procedure-based. I liked the fact that I would go to work really hard, and then not be on call. My friends that were in OB and orthopedics and stuff were perpetually on call. Sounded like a nightmare to me. And then as one of my senior residents said to me, emergency medicine is great because we take really, really sick people, we make them a little less sick, and we send them upstairs, which is only a small fraction of what we do, but it sounded pretty fun. So it was just that it was all that, and also the fact that I felt like I was a real doctor. I could look after real emergencies, whether I was in the hospital or not in the hospital. And there's a couple of stories where before I got to med school, or early in med school, my memory is actually a bit unclear about this now when I think about it, is there was a guy, was in my house in Melbourne in Australia, and there was a huge crash outside, and I ran outside. I was actually in med school, that's right. I ran outside, and this guy had driven into the back of a car right in front of our house. Big crash, and had impaled himself over the steering wheel and was dying, bleeding, dying. And I didn't know what to do. And I was like so proud of having got into med school and all the stuff that I was learning, but I had no effing idea what to do. Nothing. And the amazing part of this story is that there was another car that pulled up behind, and this dude jumped out and said, call 911, and did this magical thing, which I now realize was just a really basic airway maneuver. And the guy started breathing, and he was drunk, and just, they took him away. And this guy was actually a resident who just finished a shift in the ER and was driving home. And that really sort of solidified it for me. It's like, if I'm going to be a doctor, I want to know how to do that kind of stuff. So emergency medicine. So you put it all together, emergency medicine.
And this was pretty early with emergency medicine, kind of one of the newest specialties. How did you decide to come to the US for your training versus staying in Australia?
Well, that was priorly determined by my wife. So I was in med school in Australia, and then I took a year off. So it's 6 years medical school straight from high school. So you come out of high school and you go into med school, it's 6 years, but you can do an extra year and do a research year called a Bachelor of Medical Science. So I wanted to take time off. I wanted to go to America because America had Disneyland and all those things. So I came to UCLA and did a research year. And literally, as I got on the plane, Sam, to go to America, my mother said, do not marry an American. So of course, while I was there, I married an American. Then we immigrated back to Australia. I finished med school. She did nursing school. And then we were actually going to go work in Africa for a while, but my family went broke. So we gave them our money and we immigrated back to the States. And that's when I did my emergency medicine training. And like you say, in Australia, emergency medicine was brand new. Where I was, my bosses were the first people to have graduated from residencies. This was in the late 80s, early 90s. So we were 20 years behind the US. American emergency medicine started really in the early 1970s, 72, 73. Australia, early to mid 80s. So it was a new specialty, but really well developed in the States. So when I came, I got to get into the residency at UCLA, which to me was stunning. But I got on the plane thinking, I wonder if I could get into an emergency medicine residency. And somehow magically, I did. There's a whole story there. My life is all about luck. The luck of this story was that there was a residency director at UCLA, Jerry Hoffman, who traveled the world lecturing, was really famous, and he hired a New Zealander and an Australian to do the residency a couple of years before me, and they were superstars. So they foolishly believed that people who had trained in Australia were good, and then I came along.
Well, you've made a huge impact, so I know for sure that he made the right decision. All right, so you magically get into UCLA, a little bit of luck, a ton of skill, I assume. And then what was your first gig out of residency? Did you just go straight into like academics, or what was it like?
Yeah, I went straight into academics. I fell in love with academic medicine pretty early on. Coming from Australia undergraduate education is fantastic. Postgraduate education is very different. It's like go away for 10 years, work in the public hospital system, designate yourself whatever residency you want to do, and then we'll give you tests that are impossible to pass at the end. And there was a lot back then for emergency medicine. It was just sort of resident on resident teaching. There just wasn't enough board certified ER docs to go around. There just was so few of them. So when I got to the States and I'm at UCLA, and the level of the education by Jerry and all of the faculty there that had trained in emergency medicine and now are teaching emergency medicine was so much better. I'm like, I want to be one of these guys. So I graduated and immediately stayed on at UCLA and the county hospital in Olive as faculty, and was at UCLA for about 10 years. And then I wanted to go to the big house. And in Los Angeles, the big house was LA County. That was the big trauma center. That was probably, at the time, the busiest emergency department in the country. And I wanted to go do some time in the big house. So I went to USC and was there for about 18 years before I retired and went back to UCLA as a professor emeritus, which means do nothing and hang out. But it was an amazing career that I got to be at UCLA and then at USC. Oliveview was a tiny little county hospital, wonderful patient group, but USC was something different. It was, I'd never done a thoracotomy in my residency. I'd never done a crike. And I'd done 6 thoracotomies and 2 crikes in the first week that I was at USC. It was like, whoa. And this was at the end of that sort of what Father Greg Boyle, who does Homeboy Industries, calls the decade of death. Every night at USC, it was just so much trauma, so much penetrating trauma. It was an amazing experience to train there.
Yeah, and then not only did you do the academic side and clinical side, but then, this is one of the things you are extremely well known for is MRAP. So how did MRAP come into fruition, and how did you launch that? Because I assume that must have taken a bit of courage, taking a leap into the entrepreneurial world.
Yeah, I never wanted to be an entrepreneur. My father was an entrepreneur, and I saw his life and I'm like, this is a terrible thing. I just want to be a professional, and I want to get a paycheck, and I want to put money into my 401k, and I don't want to deal with all the crap that goes with this. But maybe there's a gene that clicked in. I don't know. But as I was saying, the postgraduate education in the US was so good. I would send back tapes, little tapes to my friends back in Australia, like, here's some recorded tape from Grand Rounds today. And they would be like, send us more, it's so good. So I started recording that stuff, and then I just had this thought, like, I want to record all of the best lectures. It's not fair that UCLA has like the best training or USC has the best training and the rest of us throughout the world don't get that. So at some point, it got into my head, I want to capture the best lectures, not just at UCLA, USC, but across the country, across the world, edit them, and then represent them for everybody. And so Rick Picardo was my mentor, and he'd had Emergency Medical Abstracts, which was a review of the literature every month. He was very entrepreneurial. So I got into business with Rick and told him, this is what I want to do. He said, no, Mel, I don't want to do that. And so I went to Audio Digest, and I almost did this big deal with Audio Digest, but then in the end, like, well, we don't know how it's going to make money, because I was thinking about doing residency training. And then I went back to Rick, like, Rick, help me out, bro. I'm going to do this with or without you. He's like, all right, let's do it. And so that's when we started MRAP in the early 2000s, 2001. And we did exactly that model, which we took lectures that were at USC or actually at UCLA at the time, or lectures that I created myself. And then we started recording people giving lectures at different conferences around the country and editing them, which was a pain in the butt in 2001 because the programs were super slow, and I would like edit out this and it would take 30 seconds. Now it's like instant. It was like take forever. But it became really successful very quickly over a few years. And then I just kept reinvesting the money and making it better and better and better. And it went from a little tiny program and we expanded it out. So the history of it is that, it was a 20-year overnight success. It started small, but got bigger and bigger and bigger and bigger, expanded out, textbooks, more audio, more faculty. We actually stopped recording conferences because we found that the expense to quality ratio was terrible. We would go and spend lots of money, record a 20-hour conference, and only about an hour of it would be usable for various reasons. So we sort of moved it back into, let's find the best speakers and record them via Skype. Remember Skype back in the day? Mm-hmm. And now we do it via Zoom and all these other things. But now we basically collect the best faculty and have them do it sort of in a studio-like setting, even though it's a remote studio. So we've gone through the whole sort of process. And it started off with tapes, literal tapes, then CDs, and then we got rid of both of those, and now it's just all online. I don't know what's next. Maybe we'll just beam it directly into your head. I don't know.
Get the Neuralink implanted into the brainstem.
Exactly.
All right. So then after your kind of illustrious career, educational career, everything happening, you made another transition. And specifically, I remember listening to your ASAP 2018 keynote conference, and you were mentioning, hey, I'm going to hang up the white coat. And so how did you decide? You're like, you know what? I've had enough. Like, what was that decision process for you?
Well, with all of these stories, there's the long version and the short version. So I'll give you the short version because the long version goes for weeks. But when I was a resident, emergency medicine stressed me. I loved it. I loved it. But it also stressed me. Every miss, every patient, I would be like, what am I missing? Are they going to come back tomorrow? So I really took to heart every miss. And there are some people that are very confident who go into shifts and they're just like full of swagger and confidence. And I wasn't one of those guys. Al Circati and I talked about this. Like Billy Mallon goes into a shift and he's energized and he's like fired up. And at the end of the shift, he's got more energy than at the beginning. And I came out at the end of each shift, wrung out, done. Oh my God, I'm just like, So I remember saying to my residency director when I was a chief resident at UCLA, how do I retire at 50? Because I can tell that I'm not going to be able to do this into my 60s and 70s like some people. So we talked a lot about finances and putting money away. And I was aggressive about making sure that I could retire at 50 if I got to 55 or whatever and couldn't do it. By the time I got to 50, I found nights really difficult. I had a lot of PTSD about all of the patients working at a big trauma center. You see terrible stuff. I missed stuff. People died. So, and MRAP was becoming really popular. And so then I could live off MRAP. And I remember being at a shift in the resuscitation suite with a sick kid, and we resuscitated the kid, but I was distracted because I was thinking about all the business stuff, all the education stuff I would do. And that's when I realized I think my time being a clinician is over. If I'm this distracted in front of such a sick kid, then it's probably time for me to leave. I never wanted to be that attending that stayed too long. If you train in emergency medicine in the US, I think we all had that experience of there's a couple of attendings that should have retired 5 years ago, and you as the senior resident know more than them, are, better than them, and they kind of get in the way. I'm like, I never want to be that person. So I always thought I'd like to leave a little bit early than a little bit late. So I retired clinically in the US at 50. And although I still, even now, that's 10 years ago, still get this desire, well, maybe I should go back because I really do miss it. It was the right thing to do for me psychologically to leave. It was super hard, and I became a little depressed because of it. And I remember talking to Greg Henry and Jerry Hoffman and all these legends before me had done the same, and Peter Rosen. They all went through the same thing. It's like when you hang up that coat, a big part of you dies, because being a clinician is such the highest level of emergency medicine. There's lots of different types of emergency medicine you do, but seeing patients and taking that responsibility on, and that's huge. So hanging up that coat's associated with a significant existential crisis for most of us. So that's what I did in, about 10 years ago, just before that ACEP talk.
And once you hung up the white coat and you said, hey, I'm transitioning out, was it, daiquiris on the beach? Were you just like loving it? Or because you did mention, hey, this was kind of an existential crisis and a part of your identity. Or was it, tell us about that challenge post retirement.
Well, I didn't stop working. I was working full-time on education, creating MRAP, continuing MRAP. At the time, had Essentials of Emergency Medicine, which was the big conference in emergency medicine. So I was working constantly, which was good. It was a great distraction. I was still very involved in the residency. I was still giving lectures, but I stood down from the role of the voice of MRAP. One of my other philosophies was that whoever's doing the hosting of MRAP should be a clinician who's still seeing patients. Again, my bias was I'd seen people become talking heads decades after they'd finished practicing, pretending that they were still seeing lots of patients. And I'm like, I don't want to do that. So that was also very difficult because at that same time, like, I need to step down as the voice of MRAP, which I'd been since the beginning, and hand it off to people who were still seeing patients. And so that was difficult, but I was still involved and I still felt like I could do some of the education. I just couldn't be up the front saying, well, when I see these patients, because I don't anymore. So I kept myself very busy. It was very difficult, but I still kept myself busy doing that stuff. And then we started our nonprofit, and then I got to work overseas. I did a lot of work, Chile and Africa. And so I still do that every year, get to go and do rounds and see crazy patients and tuberculosis, but in a very different environment. There's no charting. There's no computers. There's no lawsuits. It's just like back in the old days, like you and the patient, a written note, hands on the shoulders, doing the best you can. So I really enjoy that type of medicine now.
Yeah, beautiful. And now I want to talk and ask you a little bit about mental health and emergency medicine, because you are one of the leaders in this field. And so we know that emergency physicians, we see a ton of trauma. We see a ton of violence. It's like you had said in an earlier podcast, like we're in a war zone. So what is important for emergency physicians and the role of our mental health in this field?
So we are in a mental health crisis globally. I mean, the pandemic created this global mental health crisis for everybody, particularly kids. Medicine is in a crisis, particularly in the US. There's so many changes going on. I call it the deprofessionalization of the specialty. Big for-profit groups coming in and saying, go faster, make us more money. And the old school physician is in charge and the professional, and I'm in charge of, my life has really changed, and that's been very stressful. There's this growth of this anti-science sort of group within society that don't trust physicians anymore, don't trust vaccinations. Basic science is going out the window. So you go to work and you're trying to help people, and they're telling you that you're bogus. And we saw this a lot during the pandemic, just a very difficult time. But emergency medicine's always been stressful. We were told when I was a resident back in the early 90s, oh, people burn out in emergency medicine because they weren't trained in emergency medicine. And it turns out now that we're all trained in emergency medicine and we're burnt out. You know why? Because it's a really stressful job. You see a lot of death and destruction, and you make mistakes, and then you get in trouble. And here in the US, you get sued, and it's just a very, very difficult job. So burnout is a real thing, and I don't think we've ever addressed it. And even now, it drives me crazy when large institutions or hospitals, they bring around, the charcuterie board. after you've just resuscitated a dead child and you've got 50 more patients waiting. And it's like, oh, it's doctor's day. Here's some cheese and a bagel and everything will be fine now. I'm like, please, that is just so effing insulting. You've got 100 patients in the waiting room because you have a dysfunctional hospital and you can't move the patients upstairs. There's all of these forces just with this moral injury. So mental health crisis in emergency medicine is huge. There's been a couple of big studies, one in the New England Journal, that looked at burnout in physicians. Physician burnout it's epidemic in all specialties. But number one, emergency medicine. We were right at the top, which was, I can't remember the numbers now because I don't have it in front of me, but like something like 65% of emergency physicians feel significantly burnt out. And we did a survey of our residents more than a decade ago and asked them about depression, burnout, and suicidality. A third of our residents had suicidal thoughts. This was a decade ago. So this is a real thing. We need to stop BSing about it. And we need to understand that this is part of the job. And how do we deal with that? How do we reduce that? How do we assess that? How do we have ongoing sort of dialogue about it? And don't get me wrong, yoga is fine. And yoga is good and makes you feel better. But this is bigger than effing yoga, and it's bigger than Dr. Donut Day. This is something we need to tackle head on. It has to start from the beginning of residency, I believe, and has to go all the way through the end of your career and then past your career, because this is literally like being in a war zone.
I really appreciate your vulnerability, and in particular recently with your book, The Extraordinary Power of Being Average, being on the various podcasts. And you're kind of really highlighting and shining the light of someone who is seen externally as kind of like a superhero of emergency medicine, but you're also telling your personal story, which I acknowledge and I'm so grateful for, Mel. So tell us, globally, we know that burnout affects, roughly 2 out of 3 emergency physicians. How did it impact you personally in your life and, kind of the struggles there?
Yeah, I didn't know how burnt out I was until I finished. Then you have the existential crisis, and then having intrusive thoughts and visions of the dead children that I'd seen, and that just keeps coming into your head. And I got a little depressed, got some help, seemed to work, and then I just threw myself back into work. So one of the ways you can suppress these things is just by working. And so, I had a very bad childhood, alcoholic mother, very abusive father, was suicidal once as a kid in my teens, got through that by luck, not by therapy, and then went to med school. And then for like 30 years was so busy, I didn't have time to be depressed, kind of thing. This is sort of a classic thing for physicians. There's so many of us are obsessive compulsive for various reasons. And then when you get to the end of the career, that's when the shit hits the fan. So that I'm just a classic example of this. When I talk to all of these therapists and stuff that I've met through this work, they say, oh, this is so common. Physicians don't understand. It's at the end of the career that the crisis really happens, because you're big and important and you're working really hard and you don't have time to work. And then you retire or get into near retirement, and so many physicians collapse at that point because they've suppressed it all. So that was me. It got really bad when I tried to step down as the CEO of my business. That made it even worse. Okay, now I'm not a clinician and now I'm not going to be the CEO. I had a major meltdown of my mental health, depression, resistant to SSRIs, then tried a norepinephrine SSRI, which I developed suicidal ideation very badly. And because I'm a stupid physician, I'm like, it'll be fine. I can get through this. It'll just go away. Didn't go away. It got worse. And that's when I had to get more help. And it led me to ketamine, which no doubt we'll talk a lot about. But PTSD in emergency medicine, I think, is universal. It's just the degree to which you have it. And when it reveals itself, it depends on the person, but it is not infrequent, and it's very common at the end of your career to start to display many of the symptoms, because you no longer have this place to suppress it. You now have to own it or not own it, as the case may be.
Yeah. Thank you for sharing that piece, and especially about your personal challenges with depression, suicidal ideation, because it's real. And we know that, roughly 300 to 400 doctors die by suicide per year. We had that really unfortunate case of Dr. Lorna Breen, which I'm sure you may or may not be familiar with, who died by suicide during the pandemic because she was just working. And there seems to be the stigma associated for doctors and clinicians who are like, hey, I'm struggling, I need help. But in a way, it's kind of like this conditioning, or we're not allowed to request that. And if we do, we have to fill out a form on the medical licensing saying, yep, I'm being treated for XYZ. So it's really important to talk about it. But at the same time, there seems to be a resistance from either, I don't know, the overlords or the medical boards. That's kind of the feeling that I get when a doctor needs help.
Yeah, that's why we need to talk about, we keep talking about destigmatizing mental health, and yet there are still systematic things in place that make it feel scary to go to the medical board and say, I've been treated for depression or suicidality. It's scary. What does that mean? And it depends on the state that you're in. And I know that, like, when I first went and saw a psychologist, it's like, do you want to have this on your insurance? Because I look after a lot of doctors, and many of them choose to do it private pay, so it's not on their insurance record. I'm like, why is that? And it's like, well, because in some states that's considered a problem. So we have to continue to work at all levels. Like, if you have cancer and go get treated and you're in remission, it's like, cool, go back to work. But with mental health disorders, there's still the stigma about what does that actually mean? So we need to demystify it. We had one of our residents die by suicide, and it was same thing, great resident, chief resident, super stellar, finished residency, had the existential crisis and died by suicide. Didn't seek help. And you hear this all the time. Why not? Because there's stigma around it, and we have to get rid of it. And the biggest problem, and this was true for me and I think for all physicians, I'm the doctor. I look after sick people. I don't get sick. And we have to get rid of that idea. It should be, you're the doctor. You have to look after a lot of sick people. We better make sure that you don't get sick, or if you do, that you get help very quickly. Because guess what? When you went to med school, you didn't stop being human. And that is really the problem that we have, that we are put on this pedestal because it's so freaking hard to get into med school. You're the top of the academic ladder, and you're placed on a pedestal, and then people are afraid to say, but guess what? I'm just human. I'm stressing out here. This is really hard, because that's not supposed to be your role. And so we need to change that and say, these people are human, and we're asking them to do superhuman things. So we better look after them, or we're going to break them. And we can't break them because we need them.
It's so important, because when I think about Earth, if I zoom out and look at human society from a global level, I almost think of clinicians, physicians, nurses, techs, et cetera. Like we're kind of like the white blood cell, the immune system. And if there's a white blood cell that is not optimized and functioning at its highest level, then I know that white blood cell will not do as good of a job as it could if that white blood cell. So because we do have this, being on a pedestal, it's like there's this expectation of, oh yeah, you got to be healthy, and you got to put up this front. But in reality, we do need to prioritize the health. And I think for you sharing your story, I think that's going to really encourage other physicians, clinicians in this space to say, yeah, hey, Mel, superhero, amazing physician, clinician, educator, he's also facing challenges. And I think doing and sharing these little stories will help.
Yeah, people ask, why are you talking about this? It's very personal. I'm like, because that's my job. Whether I like it or not, I am very prominent in the field. And so I need to be honest about it, because people will listen to it, rightly or wrongly. Like, people will listen to it. And so I feel that is my burden. That's my job. I don't necessarily like telling people about this journey. It's very personal, but it is my job to say, I talk to you all the time. I'm human just like you. Because of what I say, I get hundreds of emails saying, thank you. asking for help. Where should I go? What should I do? It's overwhelming. I go to conferences and I can't tell you how many people come up and say, thank you for that. I went and got help. So, my job is to be the canary in the coal mine. Guess what, everybody? We're not doing too good. So let's get some help. Let's talk about this. And I got to tell you, I don't think it's 2/3 of emergency physicians. It feels like 95% of emergency physicians are struggling. Not all of them need the level of therapy that I got to, but boy, everybody I talk to says, yeah, this is really hard. And it's worse now than it was 10 years ago.
Yeah. And speaking of help, one of those options would be medications. And you mentioned, SSRIs, SNRIs, norepinephrine. And what's great now is there's tools for people who need help, whether it's pharmaceuticals, whether it's electroconvulsive therapy, TMS, transcranial magnetic stimulation therapy. What for you, I know you tried the antidepressant route. Did you consider seeking other interventions in addition to psychotherapy? Because I know that's been a prominent part of your healing process.
Yeah. So I started with psychotherapy because of my childhood, lots of repression there that I had to deal with, and then never dealt with it. It's weird to be like 50 and 60 years old. Like basically you're a 12-year-old. My emotional state was of a 12-year-old, an abused 12-year-old. So I have to go back and start dealing with that. And then with the depression, we tried SSRIs, and they only work about 50% of the time. Lots of side effects. They're not the greatest drugs in the world. So even then, I have a really good primary care doc. She's excellent. She's like, if this doesn't work, Mel, I want you to know there's other things we can do. And so then we tried the norepinephrine SSRI. But even before we started that, it's like, if this doesn't work, we've got ketamine. I've got this great group at UCLA. They're doing really good work. They're doing a lot of research, and it's really positive. And we'd already been reading in the medical literature about ketamine for PTSD and stuff. So that was already the plan. So for me, we already had this sort of stepwise approach. If this doesn't work, we're going to go to ketamine. So it didn't work, and I got into ketamine therapy with this group at UCLA. And I got to tell you, it's only an N of 1, but it was magic. The neuroplasticity of ketamine, along with getting psychotherapy before, after, during, and now still continuing, really changed the way my brain worked night and day. The depression went away, but also I was able to deal with a lot of this childhood trauma. And when I say neuroplasticity, you would say A and I would say B. And then after this ketamine therapy, it changed my response, my fight and flight response, for example. I'm like, oh, what do you mean by A? Oh, I think I understand what you mean by A now, instead of having this, these pathways which were just so effed up. Now I was plastic and we could talk about it. Why do you feel like that? No, you're not an arsehole. Yeah, your dad said you're an arsehole. Guess what? You're not an arsehole. So we could change my brain, and the depression went away. I'm like, for the first time in years, I woke up, I'm like, I really am happy to be alive today. I want to go to work. I got stuff to do. Look at those flowers. It really was quite incredible. And we knew this for decades, but the history of it's kind of sad, because we knew this in the 60s that ketamine had this effect, but we stopped studying ketamine, LSD, and all this stuff because of political reasons. So I get kind of sad that we've lost 30 years and now we're just getting back to it. But, you and I use ketamine all the time, and the ER put people's shoulders back in to do this stuff. And there were these case reports of people who'd given ketamine for a procedure that also had depression. And then they're like, oh my God, I feel so much better that you've put my arm back and I don't feel depressed. We realized that one dose wasn't enough. And right now, you can speak to this much more than me, but I had 6 doses over 6 weeks, pretty standard regimen right now, which again I consider life-saving. And then a few months later, I did 2 more sort of booster sessions, and that was about 6 months ago. And I still continue to feel fantastic. Still in therapy for lots of, childhood issues that are going to take a long time to work out, but I'm no longer where I was. That PTSD has been treated, the depression is gone, and I am a new man. So I don't know if it'll work for everybody, but I got to tell every emergency physician out there who's maybe tried SSRIs and other things, there is hope. And it's not just ketamine. There's a whole bunch of meds. And some people say ketamine is probably the least effective of it. Others are disagreeing, saying, no, maybe not. But you've got psilocybin and MDMA and a whole bunch of new molecular weight entities. There's real hope here to fix your brain, to fix these neural pathways.
If you tuned in to our episode today, chances are you're curious about the ins and outs of starting up a ketamine clinic. It's an exciting field, but let's face it, the journey from idea to actually opening day can be quite daunting. That's why we've created something special for you. Think of it as your personal roadmap, a free downloadable checklist that lays out the essential steps you need to consider when starting up your ketamine clinic. This checklist is designed to help you avoid common pitfalls and launch your trajectory to success. So how can you get your hands on this checklist? Simple. Just visit www.ketaminestartup.com/checklist and grab your free copy today. We've made it easy and accessible because we believe in supporting our community with a valuable resource. ketaminestartup.com/checklist. All right, let's get back to our discussion. Stay tuned and don't forget to download your free checklist during or after the podcast.
Yeah, and tell us more about your experience, let's say the first session, because, at varying doses with ketamine, and whether, if we're using it in the ER, I'm doing, pretty high, 1 mg, 2 mgs per kg, and pretty rapidly pushed. Whereas, there's other ways to do it in a more clinical setting, which would be, intramuscular, intravenously, lower doses, infusions. So a lot of patients, when I give it in the ER, then they'll just have a complete full 100% dissociation. And when I'm using it in the ketamine clinic, since we're doing lower doses, they'll have, what I refer to as non-ordinary states of consciousness. What was your first experience like? Did you see, the pink elephants? Did you travel to different, alien land, or what was it like for you experientially?
Yeah, so we used a lower dose. Yeah, the dose I usually use to put shoulders and stuff back is 1.5. We used that, I think, at 0.5. And I went into Neverland. So it was like a Nolan movie. I was like floating in outer space and sort of at one with the universe. It's really hard to describe unless you've had one of these experiences, exactly what it's like. But yeah, sort of floating outside my body in the universe, at one with the universe, like amazed. Oh my gosh, there's so much more to the universe. But then I got a little anxious for my first time because I didn't know how to get back. And we talked about this beforehand. My therapist and doc were really good. Like the medication will wear off and you just sort of slowly come back to normal consciousness. But when I was in it the first time, I'm like, I don't know how to get back. It was like you're in the middle of space floating around. Like, where's the door? How do I get back to the real world? Because this is great. This is an amazing experience, but I still want to go back to the real world. And I didn't know how to get there. So then the drug metabolized and you slowly come back and you're like, oh, we're back here. This is cool. And then for every subsequent dose that I had, that anxiety went away. It's like, because I've been there, done that. I know this feels like, is this real world? Is the real world the real world? How do I get back to the real world? But I can see now why, and again, having given doses of ketamine to thousands of people, some people wake up and freak the hell out. And that's in part because when you and I give it in the ER, it's the worst place to give it. The lights are on, there's flashing lights, there's people screaming. And so if you're tripping, that is not a good place to start to wake up. It'll freak you out. So having a really calm environment helped, really nice music, eye shades, was able to make me transition back. But I was a little panicked that first time. So it's really important to understand and to explain to people that you'll just metabolize, you'll come back, it's going to be okay. So my first experience was a little bit panicked, but then after that, I'm like, I'm all good with this. I get to enjoy the experience and then come out of it. And as soon as I came out, we would be doing therapy.
Got it. Yeah, one of the metaphors I use is for our patients, if someone is going scuba diving for the first time ever, that first scuba dive can be a little bit scary, can be intense. So we start them with the lower doses. They get used to the space. And then on the subsequent infusions, we can bump up the dose. But like you said, the first time can be overwhelming, can be scary. But I think with each time one enters that, different dimension or where, the other world, the Nolan world, it can be more comforting because you've been there before. Now, what's interesting is for you going into this non-ordinary state of consciousness, which is kind of fascinating to me because everyone will have a different experience based upon each individual's, own genetic background, personal history background. Were there lessons or insights that you feel like came from you, or was it the psychotherapy post session that cemented it, or a little bit of both?
Yeah, I think for me it was both. We know that there's an effect without psychotherapy. There is just these biological effects, and you don't necessarily have to have therapy to have an effect. But for me, because I was dealing with PTSD, childhood trauma, it was important for me to have a very close guide to deal with all of these emotions as I was in this state, coming out of the state, thinking about the next episode, thinking about what I wanted to get out of it. For me, it was very helpful to be in this place where my mind had been expanded and now I could retrain it. And it's funny because my professors are all in their 80s now. And to a man and woman during the 60s, they all did psychedelics. And I don't know whether there's a selection bias, that these were the people that actually functioned really well with psychedelics and became physicians and professors. And then there was a whole bunch of people that dropped out of society. I don't know. But they all said the same thing. It's like those psychedelic episodes really expanded their mind and they thought it was a really positive thing. I was always scared of psychedelics. And I smoked weed once when I was in college and I didn't like it. I was always afraid of that, losing that control. So for me, having a therapist helping guide me through before, after was really important. I don't think everybody needs that, but my psyche was pretty fractured and broken. So I wanted somebody to hold my hand basically the whole time.
One of the things you mentioned in your book, The Extraordinary Power of Being Average, is the G factor.
Mm-hmm.
And as you're talking about the ketamine experience, kind of getting a expanded view, do you think that someone's G factor, the global factor, this view or perspective of, there's much more going on than just beyond me, did that expand for you, or could it expand for someone, you think, in the ketamine space?
So the G factor is based on a Kenyan kid that became part of our family, and his name's Joffrey, and he's just this loving human being. And everybody that meets him is like, there's something about this kid, little orphan kid from Africa who came to UCLA, got a bone marrow transplant, just the biggest heart in the world. You can't spend 10 minutes with this kid and him not change your life. He just loves everybody, loves everything. He just sees the world with this expansive view. It's like, look at the clouds and look at the moon, I love people. We were driving to UCLA to go and get blood draws and all this stuff. And his little brother was there with him going through the same experience, having a bone marrow transplant. And his brother was starting to freak out because going to UCLA meant getting injections. And he turned to him and said, don't worry, Ryan, that the people here really love children and they'll be good to us. I'm like, who is this kid? So this expansive view that he had, I had that during the ketamine experience. I don't have that intrinsically, but I had it during the ketamine experience. And you hear this a lot from people like, the world is love. The universe is full of love. If you can tap into that, if you see that, it changes your vision of what life is about. So I definitely had that experience, that it expanded my mind, made me believe in the goodness of the universe as a whole and people as a whole. And it all sounds very hippie and 1960s, and that's just not who I am. But it really did affect me and still does now. That I see the world in a different way than I did before, much more expansive. I basically consider myself an atheist, or I used to. So I was brought up Catholic, and I became a born-again Christian, and then I became an atheist, and now I call myself thoroughly agnostic. So experiences like this change, like, wait a second, maybe I don't know everything about the universe. Add to that what's happening with quantum theory and particles going back in time and being... quantum entanglement and stuff, like, wow, the universe, as Einstein said, is more strange than we can possibly imagine. So it's also expanded my spirituality. It's like, I'm no longer an atheist. I don't know what's out there, but I don't know what I don't know. So it's made me much more spiritual in that way as well, and which I think has made me calmer. Like, I don't know what's next, but boy, it might be an experience like this because ketamine, quantum entanglement, I don't know. I'm open to it all now.
When I've had a patient at our clinic who expressed similar thoughts, where he was an atheist, he was also a physician, and after undergoing the 6 ketamine treatments, he said, I don't think I'm an atheist anymore. I think there's something, I don't know what it is. And I don't know if I'm going to be, Christian or Catholic or Mormon or whatever religion. He's just like, I think there's something more that I'm not seeing. So it's quite profound to hear how that can shift as well. I mean, that's a big thing, right? To going from, hey, I don't believe in anything to maybe there is something out there.
Yeah, I think it makes you see the world so differently from a scientific point of view. Well, this occurred because this and this and this, and then to go through an experience like that it again really expands your mind. It makes you more compassionate. I used to hear these stories about Native Americans would kill a deer for dinner and then go pray over the deer and thank the deer for its soul. And before ketamine, it was like, that's weird. And now it's like, no, I kind of get it. It's like we're all part of this giant universe. And they're just saying, thank you for being part of it. We need to eat you now to survive, but thank you for your role in this universe. It's all very mystical but profound and important. I think it's made me a much better person, a much better physician as well. I'm much more accepting of lots of different views of the world and the universe now.
Let's talk about forgiveness, because when I listen to, the reason for this conversation is I was listening to Rob Orman's Stimulus podcast, and you had talked about ketamine therapy, and I was like, I want to have Mel on our show. But the other important thing that I got from that was forgiveness, and how the ketamine experience kind of highlighted that or helped you or assist you. So tell us about that, Mel.
Yeah, that was with Rob in particular. So Rob and I were really close. And he was on MRAP on my medical show after I stepped down, like, Rob, I need somebody to be the lead guy now. And then we went through a period where we broke up. We had a divorce, and he went his way and I went mine. And I was so angry at him. I was just pissed at him. And I didn't talk to him for years. And it felt so bad, but that's how I dealt with it. Again, like a 12-year-old, like a middle schooler. You're not your friend anymore, Sam. I'm not going to talk to you. Instead of having the fights and having the broken relationship, but working on it and trying to fix it as much as you could, I just like, nope, not going to talk to you anymore. That's where my emotional, maturity was, 12-year-old or less. After this experience, like, that was part of that re-expansion of my brain. Now, hang on, that's no way to treat a human. That's no way to treat a person. Even if I disagree with them, I should be in connection with them. The universe is amazing, and I don't know how long I've got. So as part of that process, I texted Rob and said, I'm sorry. I acted like an arsehole. I still think what you did was wrong, and you probably think what I did wrong. But we need to talk. We need to be friends or frenemies, but what I did was wrong. So forgive me. And Rob, being who he is, who's further along in the evolutionary pathway than I am, accepted that and called me immediately and said, let's talk. And we chatted, and it's just so nice to have that fixed. We'll always disagree about that period in time and the right decision that to have made, or the wrong decision, or whatever. But we're back in relationship. We're back and have a friendship. And I realized that although I hadn't done that a lot, there was a number of people that's what I'd done to during my life. And I just called them all up and like, I'm sorry. I was an asshole. Forgive me. And that burden has lifted. It's such a basic thing. You hear about this all the time, but until you experience it, you don't realize. Forgiving people unburdens you. And I had some people to say sorry to. There are some people that are now doing that to me. And I'm not angry at them, frankly. I'm like, you're going to carry the shit and you shouldn't carry it. It's not good for you. So you might not be able to talk to me now. You might not be able to talk to me next year. But I really hope you get to the point that I got to, is like, stop carrying this shit around. Let's forgive each other. We can still disagree, but don't carry around this anger and resentment. And certainly this idea that just cutting off relationships is the way you fix things. That fixes nothing. It makes it worse. We see this all the time in the emergency department. The violence, the alcoholism, the divorce, the terrible things that happen when forgiveness just doesn't happen, when communication just stops, things just explode. So I've really set it my task, like, who have I pissed off? Who am I not in relationship? Who do I need to forgive? And I've gone down the list, baby, top to bottom, down the list. And it's been such an unburdening of my soul. I cannot tell you. It's been great. The only thing I feel bad about now is why the hell didn't I do it earlier?
There's a saying, I think it's attributed to Buddha, who said, holding onto anger and resentment is like holding onto a hot coal while you're waiting to throw it at someone. It actually hurts the individual holding it. So it's really powerful being able to let that hot coal go, because it's hurting, us when we hold on to it.
Yeah. Yeah, it's so important. And ketamine was part of that. Maybe I was going to get there with therapy at some point, but boy, it accelerated it. It was after like the second session, it was like, hang on, I got some work to do with some people. So for me, it was all part of that experience, and it just accelerated it.
Let's say that someone is listening or watching to this interview, and let's say they're an ER doc, maybe in their 30s, 40s, and they're kind of struggling with either burnout or depression or anxiety, but yet they're afraid to take the leap and ask for help. What would you say to that individual who's listening and like, yeah, I don't know if I can do this. This is a big deal for me. I don't know if, if I can actually do it. What would you tell them from your perspective now?
Go get help right now. Don't screw around. Go and talk to somebody right now. Now, there's a lot of quacks out there, but you're smart, you're a clinician, and you can talk to friends, you can talk to experts, and find the people that can help. There are people out there that are expert at this kind of work, and you can get help. There's therapists, there's physicians, there's groups. Our knowledge is expanding incredibly quickly right now. There's multiple therapies. It's not just pharmacotherapies. As you said at the beginning, there's a lot of other therapies that are helping people. I did an interview on MRAP with somebody, rapid alternating eye movements, really worked well for them at the end of their emergency medicine career as they were transitioning. So there's a lot of things. So I would say if the yoga isn't working, then you immediately should go get help. It will not get better by itself. You just need to get help. And there are so many novel therapies which are really helping. Ketamine may not work for everybody, but there's so many other novel therapies. So go and seek help and look at the literature. Like me, the first thing I did, because I'm a science guy, so I started pulling all the literature. Let me see if this is for real. Oh, look, randomized trial. Oh, case series. Oh, this is actually a thing. This is real. Doesn't work for everybody, but there's a really positive effect in a lot of people. So do your science geeky stuff and then go find some groups that do this for a living. They're out there. There's a lot of them.
Yeah. And speaking of literature, one of the articles that you mentioned, which is not terribly scientific, but it is published in the the American College of Emergency Physician Annals of Emergency Medicine. And I have a copy here. And you had mentioned it in one of your interviews. The title of it is Looking Down River by Tyler Jorgensen. So tell us a little bit about this, because you're the one who pointed me towards this.
Yeah, so Tyler wrote this, I think it was like a July or something like that. I interviewed him like as soon as it came out. It actually hasn't been on our show yet. It comes out next month on our show. Very similar experience. ER doc, functioning at the highest level, depressed at the end of his career. Like, oh my gosh. And he did a series of these non-sort of therapeutic, rapid alternating movements, electrical stimulation things, which again, a few years ago, I'm like, that sounds bogus. But there's actually really good evidence for it. Really, the summary of that article is the same thing. It's like, get serious with this stuff. This is real. It is almost ubiquitous within emergency medicine. And there is all these alternate therapies. And like me, he's like, yoga's great, but that's not going to get it done. This is really serious reforming your brain stuff. One of the things that comes up for me is I think this is so important. I now believe that everybody should be in therapy from the day they begin their emergency medicine career. And I would love to start seeing some work on prophylactic use of psychedelics and psychedelic therapy, because maybe our professors in the 60s had it right. Maybe you should be having an experience like this every month as part of your mental health. I don't know, but I want to start seeing some research on this.
And what's fascinating is there's some research happening, not necessarily on the human level, but again, I'm like you, I'm kind of a science geek, so I read pretty much every article that's published on ketamine therapy. And they took rodents, and again, the rodents and the human model, and is not entirely accurate because we are much more complex than a little rat. But they gave rodents, they randomized them and gave, either placebo or ketamine, and they did something called the forced swim test. And what they found was that the rodents who received the ketamine, they were more likely to swim for a longer period of time, so less likely to give up. So this idea of prophylactic treatment, because we know that people are going into the battlefield. Like, we know that's going to occur. But can we do something before it gets severe? So I think that's a really fascinating area of research for humans and physicians.
Yeah, and I don't know if it will work, but if you're already at the point where you're feeling burnout, then do all the things that we all say to do. So eat well, be careful what you drink. Emergency medicine, alcohol, it's a terrible drug. It's great socially, but it is a short half-life, and it makes you feel better for 5 minutes and then makes your depression worse the next day. So eat well, exercise, do all the right things, do your yoga, talk to friends. And if that's not working, step it up, get a therapist. If that's not working, now let's think about some pharmacological interventions. If that's not working, let's think about novel therapies like ketamine, psilocybin, other things. There's a big list. Don't be afraid to go down the list, because we need you to do this job. I mean, selfishly, we need you. If we burn out all the emergency physicians, we're screwed. We need you at the front lines. And so our job is to make sure you stay there. Now, one of my other big things, and I've said this my entire career, is that I think emergency medicine should not be a full-time job. It's too hard. You need to, and I see these groups where they've got their docs doing 20 shifts a month. I'm like, that is not possible. No normal human can. We all know that random doc who just loves it, who can work 25 shifts a month and they're good. That is the exception that proves the rule. This is a very difficult job. And one of the things you need to do is have a lot of time, because we're doing all this stress and then we're effing up our circadian rhythms and doing days and nights. And that alone will make you depressed and is the cardiovascular equivalent of 2 packs a day. So try and reduce the number of shifts and get your mental health in line and go down the list if it's not working. But take time off. Going night, day, it's like, no wonder we're stressed. Just that physiological stress alone is ridiculous.
Yeah, that's beautiful, because I think about health as kind of like building a house or maintaining a house. And we don't just use one tool, and it might be yoga or it might be therapy. We want to use as many tools as possible. If I'm building a house, I want to call the carpenter, I want to call the painter, I want to call the demolition people. I want to, find the person who specializes in kitchen and tiles. Similarly, with mental health, we need to use as many tools as possible. And sometimes when one tool works or it doesn't work, then we need to shift to the next tool and just keep on doing it. Because although I think ketamine therapy is great, it's one of those tools, but I don't think it's the magic bullet. It's not the thing that's going to cure everything. It's like, yeah, let's use this tool. It's a very powerful one. But in addition to that, there's 10, 20, 30 tools that we're going to use to really optimize our mental health.
Yeah, and I would say something also about all of that plus finances. I talked about me. I'm like, I had pretty good insight. I don't think I'm going to do this until I'm 60 or 70. Preparing for that, physicians, we're so bad at finances because we just went to med school and we worked really hard and then we're doctors. And think about your finances. I've seen residents do this all the time. They're really stressed. They graduate. Now they've got a pile of money and they start buying toys to make the pain go away. They buy the fast car. They buy the boat. They do all this stuff to get that dopamine surge, and then they're in incredible debt in addition to whatever school debt they have. And so it's really important to understand that finance is a big part of the stress. And particularly if you already have huge debt, let's get rid of that debt as fast as we can. Dave Ramsey and all those experts out there will tell you, get rid of that debt. Let's put some money away for the rainy day fund. Buy a house, depending on where you are, is a really good idea. But buying the toys to make yourself feel better is like drinking too much alcohol. You'll feel better for a moment, and then you're going to feel much worse the next day. You've really got to resist that. We've had such delayed gratification through high school, college, med school, residency. You're like, I just want to drop cash on toys. Give yourself one little toy, but make sure you pay off your debt and are financially secure, because there's nothing worse than going to work depressed, burnt out, saying, but I have to, because I got $20,000 worth of debt I've got to deal with every month. So much better if 5 or 10 years out, you're like, I'm debt free. I can work 2 shifts this week if I want to, because I don't need the money. That's where you should be trying to get to as well.
Yeah, I love that. Just keeping things lean. And I know, one of our colleagues, he says, live like a resident until your student loans are paid off. Because I know some, med students are graduating with $250,000, $500,000, $500,000 worth of student loans. And it's like, and then they pile on top of that, the boat, the car, the fancy house, the doctor house, because of the image to maintain. And it's like, well, I have to work 25 shifts a month. I have to, pay all this off. So I think keeping it lean and being financially cognizant is crucial.
It really is. And we had in my class, we had a couple of people that bought all the toys, but then we had a guy called Tom, and he did exactly that. He had a huge amount of debt, had no, financial support, and basically said that out loud. For the next few years, I'm going to live like a resident with one thing I'm going to do for myself. I'm going to buy a nice car. I really like cars. I'm going to buy myself a nice, but that's it. Otherwise, I'm going to live on my resident salary. And within 2 years, he'd paid off $250,000 and was debt-free. Like, dude, that is amazing, impressive. But then he could make decisions for how many shifts and lifestyle choices, whereas other people didn't do that. And they were going to shifts depressed and felt caught. Like, I have so much debt from all of the stuff that I've done. It's crushing. I have to do, like you said, I have to do 20 just to keep ahead. So avoid that. That'll make you depressed on top of all the other stuff. It's a hard thing to do, though, because you have deferred and you're like, can I stop deferring gratification now? Yeah, defer it a little bit more, just a little bit more. Get rid of that debt.
Yeah. And that's also one of the key lessons or insights from starting up a ketamine clinic too, is if you start out your ketamine clinic practice with a ton of overhead, and now you're paying the, $10,000 a month for your lease, it adds to the stress. So I think that not only applies to our personal life, but also the business life as well, to keep things lean when someone is starting up a company or a business.
Yeah, we could talk about that for another hour, but that's what I did with my business as well, is I never took a loan, not one. When I made a profit, I reinvested, made a profit, reinvested. I didn't want to have any debt. I didn't want this to be another stressor. And a lot of business people outside is like, how much debt do you have? I'm like, none. Like, well, you're crazy. You're supposed to carry debt. I'm like, no, I didn't go to MBA school. And I know that's what you all think, but to me, debt is crushing. So no debt for me. The only debt I have is my mortgage on my house.
Beautiful. I want to shift gears as the sun begins to set on the interview. And these are some fun questions just to mix it up a little bit. Okay. Mel, first question. What is your favorite emergency medicine procedure?
Oh, man. Oh, there's so many. I probably just intubation. There's so many great procedures, but there's something about the fact that I take a person that's breathing and I push drugs to make them stop breathing. And if I don't get it, I'm in deep trouble. Yeah, just intubation was just so fun, but I like all of the procedures.
Beautiful. And I know you also do you've done consulting work for TV shows, like, for example, ER, and now the new show coming out, The Pit. When I see these medical shows, I'm like, oh man, they got that wrong, or they got that right, or, oh, they had a consultant. What is one common error that you see that you're like, oh, you guys, you need to fix this XYZ? Is there a common theme that they kind of get it wrong where your expertise comes in?
If you look at some of the medical shows, it's the procedures where they get them totally wrong. So there was just Joe Sachs, who is on The Pit, and he was on ER as the lead medical writer. He's an ER doc who's about 5 years ahead of me at UCLA. Sent me a picture from one of the other TV shows where they intubated the patient and are ventilating them with a Yankow sucker. And he's like, and on The Pit, we will not make these medical errors. Some of them are just so humorous. The biggest problem with these medical shows, though, has traditionally been CPR. So there was some great studies that came out in the 90s that showed that they looked at all of the medical shows on TV, and if somebody had a cardiac arrest and got CPR, what was the chance that they'd live? And the chance that they'd live was something around 80 to 90%. That 8 out of 9 of these characters in these shows would walk away. And that was a problem because you and I know the number is like 1%, 2%. So people believe out in the community that CPR is this magic thing, and if you have a cardiac arrest, CPR will save you. No, it won't. So setting expectations, I think, is really important. These medical shows can make people believe just wildly incorrect things about medicine. And so that's why I really like working with Joe, because he cares about making the medicine as accurate as possible. In the early days of ER, it was just everybody lived, they were doing thoracotomies and brain transplants in the ear, and he came on like, no, let's like make this realistic. There's always a bit of a tension though, because you do want to make it dramatic and fun, so you can't make it completely realistic, but he goes out of his way to make it as realistic as possible. I'm really excited about The Pit coming out because it's going to be intense, and the scripts are really pretty great. And he's not shying away from all of the issues that you and I talked about, like the corporate takeover of medicine, boarding, not being able to get patients upstairs. All of that's going to be part of the show, so I'm excited about it.
Yeah, I've seen a few of the trailers for it, and I was like, oh yeah, this looks like it's going to be a really good show. Let's see here. All right, so another question, Mel, is going back, I don't know, 30, 40 years. Let's say for some reason you could not have been a physician or done anything in healthcare. What area or field would you have gone into instead?
Boy, I think about this a lot. Now, I'd say an author. I really like writing. I have dyslexia and I can't read very well, but I really like writing. I like performing. So like my 12-year-old self, kind of would have been cool to be a rock star. And acting, I really like, because as Greg Henry has said, medicine is show business for ugly people. And that's me. I really like that performance stuff. I've never done comedy, but it would be fun. I see like the Jerry Seinfelds and stuff, and they're such intellectuals. Comedians are so intellectual. Like, boy, I'd like to play with that. But I think, being a teacher of some form in the end was what I really like being. I like taking difficult concepts and simplifying them and then representing them. So probably just would have been a high school teacher.
Awesome. And if you could travel back in time and you see yourself as that young attending fresh out of residency, and you were to tell that Mel one piece of advice, what would you tell yourself when you had just finished residency?
Just finished residency?
Yeah, you just finished residency. You know everything you know now, and you're going to give that Mel Herbert back in the days one piece of advice.
I say this actually a lot to my colleagues. Understand that every shift, every patient is a story, and you get to be part of that story. And you can change that story for every one of those patients, and you are burnt out, don't want to be there, rather be at home. But that patient needs you there. And understanding the power that you have in that moment is so profound. The hand on the shoulder, the reassurance, that patient will remember that for the rest of their life. When families gather around at Thanksgiving or the various parties, it inevitably will go to a medical issue that somebody had and that wonderful doctor that they had, or that wonderful nurse, or that shitty doctor that they had, or that shitty nurse. You get to be that wonderful doctor because this is a profound moment in their life where they were scared, even if they didn't have something bad. They didn't know it was bad. And you got to say, you're okay. You're going to be fine now. We're going to look after you. Understanding that for every single patient encounter is what I would say to myself, and try and remember that every shift, every patient, every interaction. This is a profound moment, and you get to add up all these profound moments over your career, and don't take it for granted. That'll get you through your career. You are a priest to these patients, and take on that role, and they'll never forget you.
Thank you. Thank you for sharing that beautiful wisdom. And I know that has impacted me, and just knowing, being conscious of the impact we can make for our patients. And it's actually gratifying in a way. There's a self-interested component, because when I do that, it actually makes me feel better as well at the end of the day. As we wrap up, two last questions. The first one is there anything else important that we haven't discussed? Anything else regarding ketamine therapy, emergency medicine that you want to share? And then the final question will be, where can people find you at if they're interested in connecting and learning more?
Sure. I think we've covered most of it. We say on our show, and this is to the ER docs, I'm sure you have a lot of other people listening, that what you do matters. And we just sort of touch on that. It's a profound job. It's so important. Understand that when all of the shit is hitting the fan and administration is giving you a hard time and there's corporate buyouts, just understand that your relationship with the patient is what matters. Your relationship with your colleagues, with the cleaning staff, with the people who work in the cafeteria, you can change the milieu of that hospital by showing compassion to everybody. And that takes some effort, but it'll be worthwhile, and it'll become this tumbleweed. You'll start to show compassion. Other people start to show compassion, and you can really change that environment, that microenvironment. You might not be able to change healthcare in the United States, but you can change it in your ER. You can change it in your hospital. So just understand the power that you have there. And you can find me at melherbert.com. My email is out there. It's mel@mrap.org. And I'm happy to talk about this stuff until I get blue in the face, because it's important. So I really thank you, Sam, for doing the work that you're doing. I think it's really important to have ER docs out doing ketamine clinics. I think these are the most trained people to do this work, along with the psychologists, but from the medicine point of view, who could be better? And offering that service, I think, is really important. We need more of them, and we need more good people. And if you're an ER doc that wants to sort of start to break up their career, go talk to Sam. Go learn how to do this.
Mel, it's been such an honor having you on the podcast and the show. You've played a huge role in my medical career as well, and it's truly been an honor. Thank you so much.
Thank you, Sam.
Thank you for joining us in this needed discussion of the mental health struggles faced by physicians, especially those in the emergency room. The fact that you're listening to episodes like this show you're committed to helping others with this transformational treatment of ketamine therapy. It's always gratifying to share insights with dedicated professionals like you. We hope you found this discussion as affirming and informative as we did. Don't forget to catch our next episode, where we'll continue to dive deep into the exciting and expanding field of ketamine therapy.